Hello, everyone. Welcome to our August Lifestyle Psychiatry Caucus webinar. We have today a treat for everyone. It's Dr. Koushik Reddy, who's an interventional cardiologist at the James A. Healy VA Medical Center in Tampa, Florida. And over the course of over maybe 16 to 18 years, he's played a crucial role in developing many programs at the hospital and now serves as Director of Interventional Cardiology in the Coronary Care Unit. He was the first interventional cardiologist to be board certified in lifestyle medicine. And he's also has a distinction, a very small group of people have this distinction of a lifestyle medicine intensivist. You can ask him more about that if you want to know what that is. He has published many papers, has been in leadership positions in the ACLM, the board of directors, and he's a founding co-chair of the cardiology MIG and the VA DOD MIG. This is just a pleasure to have him. I was just looking at his TED Talk before I joined here. If you guys, I'll put it in the chat a little bit later so you guys can see it as well. Dr. Reddy, thank you so much for joining us.
Thank you. Thank you, Dr. Marlowe, for that kind introduction, and also the organization and Dr. Marlowe both for the invitation. And I'm like, oh, wow, I am a cardiologist, like you heard. And yeah, I always tell my people, hey, look, I'm smart enough to tell you that a lot of, stress and depression have direct cardiac implications, but I'm not smart enough to pretend that I'm going to be the one treating you. So that's the extent of my, knowledge about psychiatry. But in terms of, lifestyle medicine, and I asked Dr. Marlowe, like, do you guys want me to do my conventional cardiology, like an umbrella overview of lifestyle medicine, and say, yeah, that's what we want to hear. So here we are. And again, thank you for the invitation. And in terms of the title as to how I came about that trust me, that in itself is a presentation as to why and how I came about that presentation. And that said, I have no conflicts of interest or disclosures of financial or any other kind. I've been a career, academician with the VA and the USF here, so no conflicts of interest there. And the first and foremost is, my very presence on this stage is, let me minimize this. My presence on this kind of a virtual stage is, or any across the country when I speak, is because this is actually, would advance the slide. Oh, there we go. Yeah, this is my stage. This is where I live. This is where I literally had to rush home this afternoon, handing a procedure to one of my partners to be able to be here, because this is where I trained. This is where I work. This is where I teach. So this is unusual for the likes of me to step outside the confines of that, what I call the dark dungeons of a lead-shielded cardiac cath lab, and make a humble plea for myself, my colleagues, my family, my patients, my friends, anybody who I have a reach, is to, because most of what I do is preventable. And another harsh reality is that Doug Morrison is one of the legends in cardiology. He famously wrote this, that nothing, not statins, not angiotensin receptor blockers, not beta blockers, and most assuredly neither bare metal or drug-eluting stents or even bypass grafts. The last part is the key component here, is either a cure for coronary disease or is risk-free. And for me, it's risk-free. As somebody who invades human bodies on a daily basis for quote-unquote treatment, they come with a lot of risk for something that is preventable in close to 80% of us. And that said, I'm still the guy who does some very complex procedures on a daily basis, except I do them wearing a lead that has carrots on it. I'm also an interventional cardiologist who proudly, under every pair of scrub top that he has, wears this embroidered, a carrot and a stent. It's, as you all know, a carrot is not a stent, replacement for a stent, but call it a metaphor or a message on a scrub top, a larger message. And that message is this: what Dr. Marlowe was talking about is, at the request of the VA at the national level, I recorded this in the thick of COVID in the basement of our hospital, what has now become what I proudly call the 15 or 16-minute version of what has now become my life's mission, is to spread this word about nutrition and evidence-based lifestyle strategies for the prevention of cardiovascular and many other diseases. And you can go to YouTube and just simply type carrot and a stent. It's usually the first hit, and let us know what you think. And I usually start this presentation with three questions. The first one is, what is my why? Right? My plate is already double, triple full with everything that I do as a cardiologist, and now lifestyle medicine and prevention and another responsibility. And to me, it's a fun obligation. Is because primarily because of this, we took an oath. And most physicians and most people in healthcare don't know this, that these words, the simple sentence was added to in a millennia old oath only in 1969, influenced not by a policymaker, not by an interventional cardiologist or some subspecialist, but by a single primary care physician from California, that I will prevent a disease whenever I can, for prevention is better than cure. And we take this oath not as specialists in the silos of a cath lab or a dialysis unit or an intensive care unit, but as medical students. That means this should be like the foundation of no matter where we branch off of after medical school. But boy, have we forgotten that. So the next one is, what does health actually mean to us, including as physicians and healthcare professionals? When was the last time we took a moment of time and actually try to answer this question for ourselves? That health being not just the mere absence of disease or infirmity, but the presence of total physical, mental, and social well-being. And this is defined by the World Health Organization when the organization was founded, and the definition still stands. And the next question, I literally ask this my patients every Friday when I teach. I'm going to talk to you about as to what that is briefly toward the later portion of the presentation, is to why do you want to be healthy? And if I were to put each one of you on the spot and actually make you answer this question, you will come up with some very, very meaningful reasons, very personal, or even make you write an essay as detailed, as emotional, and as verbose as that essay may be. All those categories will fall into only two broader reasons as to why a fellow human being wants to be healthy: quality and quantity. Although I'm showing this as two separate boxes, you don't need me to tell you that they are intricately related and inseparable. So what I want to do is to take you through a quick journey through a graph, plotting plotting a graph using those two reasons why any one of us wants to be healthy. Social anthropologists call this concept the rectangularization of life. Some of you may know this. Is that to do that, I want to take you back a century. In 1920, an average person in this country died at 45. And quality of life went down very rapidly. That's why I kind of cringe when people say good old days. No, olden days were not good. And for those reasons, the graph looked like a triangle. In 24, we have made tremendous progress compared to that generation. But unfortunately, our life's graph looks like this bizarre convoluted shape down the slope of which we are accumulating diseases early on. Now, why would I say that? And on the screen, I saw a mother with babies, right? Childhood obesity, childhood medical conditions, childhood disease, childhood dietary patterns, to a point that diet-induced risk is now the leading cause of disease, disability, and death, not just cardiovascular, but all. And the decision that we're making as a society to wean our babies of breastfeeding at 6 months has generational implication. Childhood obesity like none of us ever imagined possible. Diabetes and male sexual dysfunction are on the rise like I never imagined possible when I graduated medical school almost 30 years ago. Hypertension and hyperlipidemia combined close to 65% of the population that we know of, and no wonder heart disease continues to be the leading cause of death, a stroke or two, and congestive heart failure. Yes, I am living longer, but guess what, folks? I'm busy being dialyzed at a unit and not having fun with my grandchildren or children on a cruise ship. But guess what? I'm alive. So if you add those conditions like that, the combined loss of quality of number of years in America is about 23.6 years. That's how many years an average person is losing to lack of quality in his or her life. What I argue is can we at least make an attempt to maintain a quality of life at a very high level? And come the time, I randomly chose 100 and we drop. I call this concept simply the concept of living longer and dying short. Now, from a triangle to a bizarre convoluted shape, the graph looks like a rectangle. Hence, the social anthropologists calling it rectangularization of life. I simply call it life in a box because no matter how hard I try, sooner or later, That's where we will all end up. If I may paraphrase one of my mentors, Kim Williams, I don't want that fault to be mine. And meaning I'm not afraid of death. I just don't want it to be my fault. When I say my fault, I want to bring this to your attention that health being an inside job for the most part, of course, there are exceptions to this. So much so that I actually break the word heal, healthy, into heal thyself. That said, again, when I use the word fault, it is not with the intent of shaming somebody or blaming a person, individual, or a system, or a society, but it is the intent of bringing to everybody's attention that for the most part, staying healthy also comes with a sense of personal responsibility. When it comes to that, these words written in Chicago Tribune in 1975 ring true even today, that the idea of preventive medicine is faintly un-American. It means first recognizing that the enemy is us. Now, I'm not trying to blame or shame anybody, but the idea is to bring to everybody's attention this clear distinction. Majority of what we do is not health promotion. What we do is disease management. Skillfully inserting 2 stents into somebody's coronaries while disease is preventable in the midst of an ongoing massive heart attack is not health promotion, it is disease management. And I can give you limitless examples like that, so much so now I question our own paradigm if the letters MD next to my name merely mean manager of disease. What diseases are we talking about? These are not some rare, autosomal recessive disorders. These are common bread and butter. Everybody, almost every single one of us have someone within our first circle of life are currently suffering or lost a battle to these diseases that are affecting 6 in 10 of us with at least with one, 4 in 2 of us with at least 2, costing us enormous amount of money in addition to loss of life. Now, just want to make a point. I picked the leading causes of death in 2020, the year of catastrophic global pandemic where everything was chaotic. Policy, public health, politics, everything was, and personal protective equipment. In the middle of that chaos, COVID-19 killed 345,000 people in America. Would you believe me if I told you in that disastrous phase, heart disease that is preventable in 80% of people killed twice as many people? The only year this was not the case, where heart disease was not the leading cause of death in America, was for a very brief period during the 1914 pandemic. Same thing continued in 21, 22. But the trends of this cardiovascular disease have not been, as bad as we think. We have made actually a tremendous progress compared to the 60s and 70s. We call this concept the concept of bending the curve. And a vast majority of this bending the curve is primarily due to single public health policy of telling America to quit smoking or tobacco is bad for you. And we're still, seeing the benefits of that one singular public health policy. But unfortunately, what we call in cardiology the golden era of cardiovascular medicine over the past 2 decades, it's as if somebody took a ruler and flattened the curves. We are no longer bending the curves. If anything, there is a slight uptick despite all the advances in medicine, pharmaceuticals, policy, or systems improvement. I should not say policy, systems improvement and procedural skills. And because of this, right, when I came to America in 95, there was not a single state in the union where the obesity rate was more than 20%. Today, we cannot find a state in the union where the obesity rate is less than 20%. All of this happened in just in one generation. And as a consequence of that, the biggest killer is making a deadly comeback, killing younger people, killing women who are non-smokers, who are falling victims to a preventable disease due to combination of skyrocketing obesity and diabetes. To showcase this to the general public about how dangerous this is, Wall Street Journal in 2019 wrote an essay about a young man who had been taking his blood pressure medications, been taking his cholesterol medications, exercised and ate healthy, quote unquote, but unfortunately died of a massive heart attack at 49, leaving behind a beautiful family. Now, if that's the case, I just want to show you in terms of secondary prevention, how are we, every time we say we, when I'm talking about society, healthcare professionals, and the general public, how are we doing by individuals who have established heart disease? These are the highest risk when it comes to cardiovascular disease because you already had an event, a stent, and a bypass operation. What percentage of those people as of 2022 are meeting ideal cardiovascular, risk factor control status? Turns out diabetes is controlled in less than half of people. Same thing with blood pressure. Cholesterol numbers are not controlled in 70% of people, right? 80% BMI is not controlled. Same thing, 22% of people are still smoking. Physical activity, 80% of people, almost 80% of people are not physically active. Now wait for the shocker. While diet-induced risk is the leading contributor to cardiovascular disease, what percentage of Americans with established heart disease are eating a healthy diet, not as defined by the American College of Lifestyle Medicine, but as defined by the American Heart Association? You ready for this? 1%. And no wonder the editorial that went with this research paper called the current situation, the failing cardiovascular health, a population level code blue. Right. So if that's the case, if the current trends continue, every single cardiovascular risk factor is expected to go up anywhere between 20 to 40%. And in addition to risk factor, the disease burden is expected to go up by somewhere between 30 to 35% by 2060. That is the prediction. If this is the degree of burden in America, is America engaged in empowering itself in acquiring the knowledge to prevent a disease that's killing this many of us? To do that, I did a national Google search in 2019 to see if heart disease shows up. And as Mike Greger would say, some of you may know who this man is that he's frustrated that nobody Googled how not to die from heart disease. So while I come across like I'm blaming the society, how about my own community as in cardiovascular specialists? So a colleague of mine, not too far from here at UF, they did a beautiful analysis of a survey of 930 cardiovascular health professionals. 90%, while diet-induced risk is the leading cause, reported minimal or no training. Minimal or no training in nutrition, right? Observation one. Question number two was, Mr. and Mrs. Cardiologist, is nutrition important to you? And 80% said yes. Almost close to 90% said absolutely, nutrition is important. How important? Is this your responsibility to teach this to your patients? Absolutely. 70% of us said close to, I would say about 68, 70% said yes, it is, we have to teach this to our patients. So far, so good. If that's true, again, Mr. and Mrs. Cardiologist, are you being the change that you want to bring to the world? Meaning that, are you eating 3 to 5 servings of fruits and vegetables as outlined by your own societal guidelines? Turns out 70% said no. No wonder heart disease continues to be the leading cause of death amongst American cardiologists. So hence, there is an urgent unmet need that needs to start here with our children. This is the prevalence of cardiovascular risk factors amongst American youth. I just want to draw your attention to the red box that just popped up in the middle of your screens, is ages to 12 to 19. When the American Heart Association surveys this every year, ages 12 to 19, the signal for healthy diet score shows up as 0.0%. It is statistically undetectable. It is not some utopian, unattainable, crazy, like, it is a very healthy, practical, doable American Heart Association healthy diet. We don't invest in that when we need to invest in that window of opportunity, 3 to 5 years, I would say even earlier, because prevention is a lifetime continuum. When people ask me how early, I say from womb to tomb, or from lust to dust. Or if you're a Hindu or an Indian in origin, I joke around with my community saying that you should have started lifestyle medicine in your previous life, because if you didn't, karma is gonna come back to haunt you. Because if we don't do that, look at disease scores on this classical New England Journal of Medicine paper. If we don't invest in our children's cardiovascular health, the risk of events goes exponentially higher. So, and as a consequence of that, we pay a price, and most of that price, in addition to loss of life and suffering, in terms of actual dollar price, majority of that goes into hospital care and physician services. For that reason, our hospitals are constantly full, and I happen to be one of those people who believe that if our beds are filled, it means that we have failed. Right? And I should not even be a person doing these type of presentations because I have no training in prevention. I have no training in primary. Well, I did have training in primary care, but I'm an interventional cardiologist who's eagerly waiting in a cardiac cath lab to save people's lives when everything else fails. The only reason I'm stepping out of the cath lab, rushing home on a work day to do these presentations is, folks, because we as a society are failing everything else. And here is the proof. People who are actually trained to keep us healthy are the least financially rewarded. If you don't believe me, I'll give you a classical example of smoking cessation. I can't think of, outside the context of public sanitation, antibiotics, and vaccination, I can't think of a better or more influential, public health policy or counseling. Is smoking cessation does not even pay a physician a single RVU. The same patient shows up to my cardiac cath lab, well, not mine, but I work for the VA. But if I were to be in private practice, I do an elective stenting of the procedure. That procedure pays me 45-fold higher dollars, not 45%, but 45 times more money. For that reason, we have this inverted pyramid where the entire care is in tertiary medicine, secondary care. So the onus is on all of us to flip this pyramid back on its health, back on its base, where the system, which is all of us, actually cares for health. So how do we change that? In asking that question, I show this beautiful, question mark shaped vegetables. But the New York Times last year was not so kind. How do we fix the scandal? That is, they called it scandal, that is the American healthcare, right? So what can we do, right? There's an information piece that is today's lecture or presentation, right? But there's also an implementation piece, which is massive. How do we take the science of lifestyle medicine and prevention to make it practical, accessible, and also financially viable? But in America, if it doesn't make monetary sense, it ends up becoming nonsense, right? That's the capitalistic model. So to do that, nobody comes even close to what the VA has done, right? We produced a document called the Whole Health Passport. It's a turnkey event, public property. Anybody can download it and implement a lifestyle medicine practice at a massive practice or a small scale practice. It's available, the Whole Health Passport. There's a policy piece that's missing, which is the National Academy of Sciences took the VA's model and they built a policy model around it and implementation models, and they called it Achieving Whole Health, a new approach for veterans and the nation. And the center is what's shown in the diagram, is that very intricately linked the concept of whole person health, where you start with you being mindfully aware, and then you build these circles and support systems about working your body, surroundings, personal development, food and drink, recharging your mind, body, and spirit, family and coworkers, that kind of stuff. To do that, I run 2 clinics, and I'll be more than happy to do any additional discussions and presentations as to the operations of those clinics called Heal and Calm. At the VA, I run them on every Friday. But in terms of policy or implementation, I want to discuss 3 slides about how do we do it. Is primary care. It's not the cardiologist or endocrinologist. The onus should be on primary care physicians, and they should be supported. Not just the onus, but the support should go to primary care. But the question is, what is high quality primary care? Is pay for primary care teams to actually care for people, not doctors to deliver services. Ensure that high quality primary care is available to every individual and family in every community. If they don't have it, we need to train teams where people live and work, right? And design information technology that services patients and family. And it's an interprofessional team. And it's accessible and implementable across all states in the country. And here is another model that was recently published in a European Journal of Cardiology, is where it's a continuum of care where you identify people at risk, go to general practitioners or a primary care doctor, register them into a healthy living program. What a novel concept. What a novel concept where there's a teamwork of dietitians, psychologists, psychiatrists, right? Exercise physiologists. And then the meetings could be in person and groups, right? And then and all use all the digital tools and follow up. And this is the one, and then you keep them healthy. It's not this endless loop of diagnosis, disease, hospitalizations, and death, right? So, but that's another entire discussion. But in terms of information and education is what we're going to talk about, is the pillars of lifestyle medicine. To that end, American College of Lifestyle Medicine and the American Board of Lifestyle Medicine are on a mission to spread and empower physicians and anybody in healthcare to learn the skills of how to educate ourselves and take this message to implementation. But to do any of that at a patient level or at a personal level is to be mindful. Mindful about what? The kind of mindfulness I teach is not the kind that I expect people to attend one of my presentations and show up next week with a halo behind their head and a rosary in their hands. That's not the, although that would work for a lot of people, of spirituality-based mindfulness changes behaviors. But the kind of mindfulness I talk to my patients and friends and families about, be mindful about one thing, the answer that you gave me when I asked you, why do you want to be healthy? And once you're mindful about that, the journey doesn't have to be perfect, but it has to be a process towards betterment. And to do that, you guys know this better than a zillion times better than I do, is that it's not that just because you want to be mindful, you're going to transition into a mindful person, but it's a process where you start with the beginner's mind, be non-judgmental, take time, acceptance of both successes and failures, and don't make it a competition, especially don't make this process a competition about weight loss, and trust the process. And if everything fails, start all over again. And I like showing this beautiful cartoon, and I don't know where I got it from. It makes a lot of sense to me, is that somebody went through this path and he or she is now on top of Mount Health, and they're doing us a favor and saying, guys, don't struggle. We know the path. Here, take a ladder. Heck, take 2 ladders, except that they pull a trick on us. Which ladder would we take? Right? That's all I ask my patients is take those steps. Take those steps so you don't, or you're less likely to step into my cardiac cath lab or the CCU. So now let's go into the evidence. Is it all just talk or is there evidence, right? So the first and the foremost thing I want to talk about is social support. To do any of this, without social support, none of us are going to succeed. This is like the foundation. The way I view lifestyle medicine is the social construct is the foundation. And the beauty in that social construct is that within those, shared relationship is there is a sense of being cared for. There's a sense of being loved. There is a sense of self-esteem that builds into that network of mutual obligations. And then you're more likely to do consistent health promoting behaviors. And the current Surgeon General and the National Academy of Sciences have done an amazing job of putting these 2 documents, one in 22, one in 23, extensive scientific documents actually outlining the disaster of a pandemic or epidemic that we have of loneliness and social isolation leading to not just cardiovascular, but many diseases. And I strongly urge, if you haven't yet, to go through that very long and almost like combined 600-page documents. But similarly in cardiovascular health, in the cardiovascular journals, this is a hot topic because poor social connections lead to poor lifestyle and poor psychological behaviors. And that leads to poor adherence with, again, health behaviors, doctor's appointments, medications, and when they need procedures. And one thing leads to another. Your blood pressure is going up, your BMP is going up, your creatinine is getting worse. Before you know, you're diagnosed with, a bunch of diseases and mortality. And just from a heart disease and a stroke perspective, people with poor social relations significantly increase risk of both heart disease and stroke, right? These are pretty influential papers. And the next pillar is avoiding toxins. The reason I showed tobacco is that, we were in a country not too long ago, were, ignorant enough to show despite having pretty solid information, put pregnant women lighting up, and advertisements read that it helps you deliver a smaller baby, or cardiologist, or men dressed up as cardiologists with a white coat that read the best cardiologist in town smoke Camels. If you really want to go into details, suggest reading that book, The Cigarette: A Political History. It's an eye opener. And here in the previous slide, I said doctor's choice is America's choice. It was intentional because that was one of the campaign slogans by the tobacco industry. But today, what do I mean by doctor's choice being America's choice is because I practice and many doctors practice in hospital systems and where we allow the sale of burgers, balloons, and bypass operations on the same floor. If we do that, I have a simple question. Do we have the moral authority to look in the eye of our patients and say, eat healthy? Right? The next pillar is, and the next toxin is alcohol. If you're emptying bottles of red wine, do it because of 25 other reasons. But please don't drink alcohol thinking that it's good for you because it's not, it's never been, and the data is just keeps on piling up. And based on this very large UK Biobank study, it kind of concluded that there's actually no safe limit to alcohol consumption, even when it's a habitual drinking. And based on that data, the World Heart Federation in 2022 changed their position, stating that there's absolutely no safe limit. We are hoping in the US that the next version of the ACC/AHA guidelines would follow. Stress, I don't need to talk to this audience about stress, but New York Times called it a very nice review for lay people. Stress may be your heart's worst enemy. And we know this from this famous paper in 2004, at least in cardiovascular medicine. I tell my fellows that this should be tattooed on your hands, that, influence of every single risk factor versus what happens when you add the piece toward the right of the graph is for any single risk factor. If the piece are the psychological and social stressors, the risk of events goes up exponentially high. And I was able to partner with a couple of big names and write a book chapter on this a few years ago. The next one is physical activity, right? It's very poor. Number of people who are physically active is just it's really bad. And the kids, not even a third of America is meeting the bare minimum guidelines. We are not expecting people to come back with six-pack abs and supermodel bodies. This is what we are expecting to do. Go for a walk 5 days a week, 30 minutes if you can. If you're able to run, at least 3 days a week, and then in the middle, at least 2 sessions of strength training, because the psychological benefits, the anti-arrhythmic benefits, the clot prevention, antithrombotic, the benefits are limitless. The benefits are limitless, so much so, if you are an elite athlete, or if you're on the lower side of your VO2 max compared to an elite athlete, your risk of dying from any cause has a hazard ratio of 5.0, 500% higher risk. Okay, and that's how it compares to smoking. And exact same data was duplicated from a VA database showing the hazard ratio of 4. Age and gender matched individuals are not based on a VO2 max from your iPhone or an Apple Watch, but objective treadmill testing. So exercise is literally medicine. And every step counts. And the most benefit, this is what I tell my patients, is just start walking. Don't count. Just from doing nothing, even at 1,000 steps, 2,000 steps, just look at the gap, just look at the slope of those curves. Right? And the next pillar is sleep. And nobody said it better than Gandhi himself, that each night when I go to sleep, I die. And the next morning when I wake up, I am reborn. Right. And that's another phenomenal book by Matt Walker. And I strong anybody in the lifestyle medicine space probably knows. If not, please read that book. And although Gandhi said those words with the tone of philosophy, the man's words came to be true, is that the magic window is somewhere between 7 to 8 or 6 to 8, something like that, of nocturnal sleep for all-cause mortality, CVD, anything to cardiovascular and diabetes. And now, some objective data is coming out from large data sets that less than 6 hours and more than 9 hours is there is a bidirectional association. Hence, people can draw some degree of causal inference, because we'll never be able to do long-term randomized sleep deprivation trials, although one was done, not long-term, short-term, a couple of years ago. Is that I think about 20 people, young individuals, same biological system, crossover design, randomized to 4 hours of sleep deprivation, sleep restricted to only 4 hours versus 9 hours. And there was a washout period of about 3 weeks. and then switched arms. Although the weight did not change much, on an average, each individual ate 308 calories in excess. But what was very concerning, right, and their truncal adiposity measurable on an MR went up by 7.8 centimeters. That is an inflammatory organ by itself. And this happened in a matter of 21 days. And we all know, those of us who, and all of us who trained in medicine, every post-call day, we eat too much. At least I did. So I'm finally happy to see that American Heart Association finally in 2022 added sleep as life's essential, right? So simple tips, consistent time to go to bed, keep the bedroom quiet and dark, temperature on the lower side, no electronic, easier said than done. But one tip that I kind of insist that my patient at least put it into practice immediately is avoiding large meals, caffeine, and alcohol before bedtime, at least when I say before, at least 4 to 6 hours. Again, easier said than done, the demands of life, but that's where the science is. And exercising helps you sleep better. Now, the next big one is nutrition. Why nutrition? Why does it? Another thing about nutrition I talk about is that don't talk about nutrition in terms of, carbohydrates, fats, and proteins. Yes, there is something, but in practicality, because when was the last time any one of us went to a grocery store, picked up the phone, called our spouse, and said, "Hey, hon, I'm at the grocery store. Should I bring 8 fats, 9 proteins, and 6 carbohydrates for breakfast?" Nobody shops like that. But why does a cardiologist need to talk about nutrition? Don't we have enough to learn about stents, right? So this is the most recent global burden of cardiovascular disease. And just look at the US. Just look at the US. The orange color coding or the pink is ischemic heart disease. That's the leading contributor to cardiovascular death. This in America. Different color codes are different parts of the world, but let's just focus here in the US. And where is that risk coming from? It says majority of it's coming from metabolic risk. Metabolic risk related to what? It's our behavior. Behavior related to what? Diet. Just look at the color-coded portion of it. That's how much it's coming from. The second one, the black portion of it, of the graph, is hypertension, which is directly related to behavior for the most part, especially nutrition. So this is why a cardiologist talked about it. So this slide is slightly out of place, but this is what I meant earlier. But the key here is this, is to avoid this type of food. Highly palatable, calorie-rich, perfect combination of refined carbohydrates and saturated fat, and we are evolutionarily programmed to get hooked onto this. 58 to 62% of American calories come from junk like this, and for each additional serving, there is 7% incremental cardiovascular mortality. Right? And nutrition in relation to cardiovascular risk factors, the most prevalent being hypertension. FDA approves a medication if a pill can lower blood pressure by 3 millimeters. Most medications lower blood pressure by 6 to 10. DASH diet, which is not even 100% plant-based diet, the original DASH trial did not restrict to salt, but if you do so, DASH diet with less than 15 millimeters, or less than 1,500 milligrams of salt a day, we can lower blood pressure by up to 20 at a population level. Let that sink in. Right? Hence, it's a class 1 indication with level of evidence A, DASH diet. Right? Same thing with lipids. Right? There is a linear relationship between saturated fat and predicted serum LDL. This is not debatable. There's a linear relationship. Right? And then when we replace saturated fat, don't replace it with trans fats. Don't replace it with refined carbohydrates and processed carbohydrates, but refine that with whole grains and mono and polyunsaturated fat foods. And same thing with diabetes. Why diabetes matters? If you're a male and if you're diagnosed with diabetes in your 30s, you lost 13 years of your life. If you're a female, you lost 16 years of life. For every decade earlier, you lose 3 to 4 years of your life. That's why it's a cardiovascular risk equivalent. And in terms of where does lifestyle fit into it, we have 3 large global trials showing that lifestyle plays an impressive role in preventing diabetes. 58 to 60% reduction in this landmark paper, the US Diabetes Prevention Program, close to 40% reduction from China with a 30-year follow-up. Same thing in Finland, 34% reduction with a 10-year follow-up, and a similar large-scale trial is right now going on in India. So hence, the plant-based diet made it to guidelines, right? And this is an impressive book by Roy Taylor on diabetes. I usually ask my patients to read this. Inflammation is a big thing in cardiovascular medicine, right? To lower that from a nutrition point of view, cut down processed foods, cut down refined sugars, eat more green leafy vegetables, each plate should look like a rainbow. And we know this from a large randomized controlled trial that was conducted at the NYU and the affiliate VA in Manhattan by Benita Shah that looked at patients with established heart disease. And she had the genius of randomizing them to a healthy American Heart Association diet and 100% plant-based diet while they are on a high-dose statin, one of the most commonly used inflammatory marker, high sensitivity C-reactive protein, compared to American Heart Association diet, while on a statin, went down by an additional 28%. Hence, a plant predominant diet made it to the guidelines with a class 1 indication, right? Same thing on the other side of the pond. A healthy diet is a cornerstone. A Mediterranean eating pattern, replace saturated fat, reduce salt intake, eat a plant predominant or a plant exclusive diet, supported by class 1 indication, top to bottom, right? And the new thing that's coming up at a federal policy and also medical society level, this concept of food is medicine. I used to say food as medicine. The American Heart Association issued a presidential advisory on this based on the White House initiative. And so did the American College of Cardiology. Actually, how to implement this. And we published a paper, and I'm an author on this paper. We just published this literally 2 days ago. The food is medicine. Food is medicine. The time is now. Now, when I say food is medicine, the time is now, and eat a plant predominant diet, there is a plant-based diet, and then there is a plant-based diet. So the healthfulness of a plant-based diet is the key because there's a clear gradient in hazard ratios for cardiovascular risk. And the exact same data was duplicated within the VA system, looking at 351,000 people, looking at their healthfulness of the plant-based diet index, and the lines separate like impressive from all major chronic diseases, cardiovascular disease, cancer, and diabetes, some of the leading killers. And that's the difference of eating healthful plant-based diet, and same observation in both ethnicities in America. So when I say eat a plant-based diet, people think that I eat like this. And I joke saying that this paper was published in the International Journal of Shaming Vegans. That's not the point, but using some very simple, inexpensive ingredients like this. Here are some of my plates. This is actually food that I cooked. This is my food. These are my plates. And speaking of my plates, this is American College of Lifestyle Medicine's plate, and we wrote a bunch of papers. Anybody wants to read on, these are the papers that I say must read. And in working with the American Society of Preventive Cardiology, we actually put a consensus document on how to actually eat healthy for cardiovascular disease prevention. And this is an unbelievably good paper by Geeta Sikand. She is a dietitian. It's like a literally turnkey bullet at item 10 strategies for preventing heart disease. And these are two, I'm going to share on one more, two free resources, one by the American Association of Black Cardiologists. The name of the book is Heart and Soul, right? And I literally print this and give this to every African-American patient of mine and their family. Go home and eat this way. Just eat off of this book for 2 months and come back. And men and women who did this, invariably, I take them off of blood pressure medication, which is a huge burden in our African-American communities. And then here is this, the federal government of the United States. We published a book, Practical Plant-Based Cooking. You want to implement this in your healthcare system, free download. Just go to Google and type Practical Plant-Based Cooking. Hands down, the best book I've ever seen, period, 107 pages. So now, does it take a courage? Does it take courage to say a message like this? Courage is a trial where we tested. Cardiologists will know where I'm going with this, but where we tested stenting versus medical therapy for stable heart disease, and there was no difference. That's where I'm using the word courage to say a different message, meaning that for an interventional cardiologist to say what I'm saying to you all today, does it take courage? So let's take a look at the courage trial. These are people with established heart disease, and we didn't know back in 2003, do we stent them? Do we put them on medication? So we did a federally funded, VA-funded randomized controlled trial, and trial finished and said there was no difference, and ensuing 15 years, continuous follow-up. And what did we find? Who are the people who did the best? Are the people, and the editorial that went written by one of the legends in the field of preventive cardiology, and she wrote, do not smoke, eat healthy, and exercise. That's what we learned after 15 years of following a randomized controlled trial for stable ischemic heart disease. But the thing is, it's not new. It's not new. People with established heart disease, this paper is written by Bernard Lown, who won a Nobel Prize, who's going to be on the dollar coin in 2025 from the state of Maine. He famously wrote that this disease can be managed medically by just risk factor management. And for having the courage and the freedom, these are all the trials in cardiology. So the non-cardiology audience, you won't get the punchline. But for having the courage and the freedom to say these words about ischemia, Bernard Lown is my hero, so much so I actually give his book to my incoming cardiology fellows as a must-read book. I also give Beth Freitas' book, the Lifestyle Medicine Handbook. Then there is another but. Another but is, doc, the disease runs in my family. We have said that ourselves. So did John Warner, president of American Heart Association, a day before he himself had a massive heart attack and had a cardiac arrest while attending and presiding over the American Heart Association annual meeting. So when are we going to go get all genetically tested? Now, this really doesn't really add much. It does not lower your risk, because here is the odds, right? Is the people with a high genetic risk who live a healthy lifestyle have just about the same event rate as people with nothing. That's the power of lifestyle medicine. And we know this from impressive trials. Multiple large-scale trials clearly showed 50 to 60% reduction in actual events, despite having high polygenic risk scores. Same thing is also true for what we fear the most in cardiovascular medicine: familial hyperlipidemia, lipoprotein little a elevation, 64% reduction. We still don't have a medication to treat this, right? Same thing, second data set showing the same thing. And in people with known heart disease, without even taking sleep into account, if you live a healthy lifestyle, you can add 20 years without an event, 20 years without an event. And if you add sleep, same thing, 20 years without an event. Impressive data. And this is a classic paper titled Healthy Living is the Best Revenge, because healthy living lowers the risk of all chronic disease by 78, diabetes by 93%, heart attack by 81, stroke by 50, cancer by 36%. And yeah, this is another thing that just came, it's not published yet, that if you want to add 24 years if you're a man and 21 years if you're a woman, these are the things. Be physically active, no opioid addiction. That was recently added. Everybody knows why that is. Smoking, stress management, diet, avoid binge drinking. Same pillars that I've been talking about from the past. And then there's another but. If there's one paper, well, before we go to the one paper, here is a gradient. Earlier, I showed you the heat map of American obesity, but here it is by race and ethnicity. This is the paper. A short read, Moral Determinants of Health, because we have become repair shops. That's what we have become. We have become repair shop of ills caused by the moral determinants of health, conditions of birth, education, work, social circumstances of our elders, community resiliency, and basic fairness, right? If you don't believe me, some of you live in New York, from Midtown Manhattan to South Bronx. Life expectancy declines by 6 months for every minute on the subway. I trained in Long Island. Right? This is true. Right? So built-in neighborhoods, healthcare access, economic stability, education, social and community context, all of these have a direct impact on our health. And that's why I love this logo put forth by the American Heart Association, where everything I said right now in that magical, life's essential eight, where everything that I said is tightly wound together by the psychological and social determinants of health. If we don't address those two as foundation of health, we'll actually be doing disservice to our patients. So my message is we have to spin these wheels of prevention through all major organizations, the American College of Lifestyle Medicine, ACC, AHA, and the Veteran Health Administration, large entities, because we have to spin these wheels. Those are our four wheels, at least for a cardiologist like myself, because our vehicle is ready to fall apart. Right? But to do this, to regain momentum towards health, every physician, every public health policy, and every action has to happen at a personal, a clinical, and a community level. A living legend of a cardiologist was recently interviewed and asked this famous question: what are the biggest research gaps in cardiology to improve care? And the living legend said, I think the most important thing is that we get rid of cardiologists. What do I mean by that is the next challenge is prevention, prevention, and prevention. So now this is my last slide. So what's the deal with carrots? That's the deal with carrots. Entire 6 pillars of lifestyle medicine. I even chose to add the 7th pillar of social determinants into my carrots. So I will stop here. These are the ways I'm fairly active on Twitter and LinkedIn, but those are my emails if you want to get in touch with me. Sorry if I went over, but I will stop here and I'm happy to take any questions.